So again, it's my pleasure to really be able to introduce this webinar today and our speakers. We're excited to learn everything there is to know about neurostimulation in the treatment of peripheral nerve pain. We have an outstanding panel. We have Mario Cibelli, Christopher Winfree, and Paul Malone, who will be kind of guiding us on this webinar today. And it's my pleasure to introduce today's moderator, Mr. Paul Malone, who is a consultant specializing in hand surgery, peripheral nerve reconstruction, and spasticity at the Royal Orthopaedic Hospital in Birmingham in the UK. His broad surgical background in plastics and microsurgery, which is complemented by advanced qualifications in hand surgery and a PhD. He's active in clinical research and training. He contributes to efforts to improve outcomes in peripheral nerve surgery and is an associate clinical professor at the University of Birmingham. And we are very fortunate to have Mr. Malone on our education committee as well. He is a key figure in driving this webinar content. So with that, I will turn it over to you, Paul.
Thanks, Stephen. What a fantastic webinar we have lined up for you all today. So it's going to be really fantastic. We've got two excellent speakers here, world experts in their field. So first of all, Professor Mario Cibelli is going to start us on. He has a PhD in neuroscience and has done a lot of work along the way in neuromodulation, really making him a world expert in this area. So he's going to start us off briefing us with some physics so that we can all understand how neuromodulation can be so effective with treating pain, moving us on to the mechanism of action for neuromodulation, including our gate control theory, taking us all through the evolution of this. Mario has been a professor in anaesthesia at the university at the moment, but is qualified in intensive care anaesthesia and pain medicine as well. He's recently completed his research fellowship at the Imperial College in London as well with him. Moving on, after Mario, we're going to go on to Professor Winfree from Columbia in the US. So again, another world expert who's going to take us through a journey with his clinical practice in neuromodulation, from how he delivers this currently through the patient need and all the various different indications. He again, very experienced, both clinically and otherwise, has worked in New Orleans, as well as currently is based anyway in Columbia University. So I'm going to hand over now for Mario, Professor Cibelli, to start us on our webinar. And please keep your questions coming in the Q&A and we'll come to them at the end. Thank you. Professor Cibelli.
Thank you very much for this very nice introduction. It's a privilege for me to be here and speak about peripheral nerve modulation, which I believe is going to be an ever-growing kind of field. So welcome to everyone to this brief lecture about peripheral nerve stimulation, which is entitled From Ancient Electricity to Modern Neuromodulation. Subheading is From the Electrofish to Minimally Invasive Therapy. I'm trying to be quick. There is a lot of information to be given about this very interesting subject, and I hope you will, get too bored after I'm going through the lecture itself. So the outline briefly is about history. I'm going to talk about early history of bioelectricity, how we moved from there to neuromodulation, which is based on the modern 1965 theory of gate control of pain. And then I will speak about some the physics, peripheral mechanism of action of the peripheral neurostimulation. And I will show you that there is, contrary to some of the other practices in pain medicine, we got already some degree of substantial evidence supporting the use of peripheral nerve stimulation. I will then move, before closing, to comparing peripheral nerve stimulation to the spinal cord stimulation, but it won't be a real comparison. It's just a pretext to speak about the pros and cons of peripheral nerve stimulation, which they're all there anyway. In a nutshell, what we're going to talk about in my lecture is that we're not just about an electric wire and a nerve. There is a lot more there. So that starts with the bioelectricity, which is not exactly neuromodulation. In the ancient Egypt, it appears that it was discovered in the tomb of an architect dating 2750 before Christ, which means we're nearly talking about 5,000 years ago, that the ancient Egyptians were using the Nile catfish, the Malapterus electricus, the fish that you see in the screen, that was used for medicinal indication. It was medicinal, it's not necessarily pain, but often it was used for pain. It was also used for the children ailments, because, at the time there was, high mortality in the children. But I wonder, how they were taking the child out of the fish after they've been treating them. The Romans followed suit, as they often did, with after the Greeks and the Egyptians. And there is lots of evidence in writing, especially from Scribonius Largus, about the documented use of the fish to relieve pain, such as headaches and guts. The fish that was mostly used by the Romans was the marble ray, which is the one that you see in the screen now, with the technical term of torpedo marmorata. Is basically interesting that torpor, what we're feeling when we feel a bit numb, comes from the use of this fish, and it was firstly described by the Romans. Going further, one of the fathers of the modern neuromodulation was Michael Faraday from Surrey here in the UK, who discovered the electromagnetic induction in the 19th century. It was 1831 to be precise. He basically discovered that by moving a copper coil inside a magnetic field would produce electromagnetic induction or electricity that could be used for many different applications, and we can see it widespread in our life. But it was then used in medicine as well. It was a clever chap, Julius Althaus. It was a German. He worked and lived in Italy and in France, and he wrote a lot about the application of bioelectricity for medical purposes. He was using it mostly for epilepsy or for treating neurological conditions, but he then soon discovered that it could be used for pain. So in the 1900s, the Electreat came to the market. He says this device, the head was a cathode and the handle was an anode that was used for the most widespread type of medical indications, mostly for pain. In fact, I found that there is a video clip, which is very interesting. You can tell it's quite a big device. There's this lady holding it by the handle. The man doesn't feel any electric shock, whereas the woman does. And they can't explain why. The simple reason is because, for electricity to be generated and go through the body, you need an anode and a cathode. Which is the reason why the wires for peripheral nerve stimulation have more than one single contact. This is an interesting thing. It went to be used up to the middle 1900s. So in 1950, it was still there. I found the manual, which is showing you the different indications from even muscle buildings and lung development, a headache, tonsillitis, regulated internal organs, even for hair loss. I'm sorry, I need to be quick. So, this is basically the structure with batteries, which I didn't think they would exist at the time, and the applications on virtually every single part of the body. And some testimonials that were added at some point in the manual showing that it could be used for infantile paralysis, neuralgia, headache, rheumatism, knee joint problems and broken bones, abscess, asthma, anything really. So on the manual, I think they probably should have said Electreat relieves not just pain. What happens next is that the mother or the other father of the modern neuromodulation through the gate control theory, which was proposed by Melzack and Wall in 1965. They basically proposed the stimulation of large diameter afton fibers, the ones which are myelinated. It would potentially inhibit nociceptive transmission at the dorsal horn. The graphic that you see here explains how a C fiber, which is commonly bringing pain message to the second neuron, once synapsing with the projector neuron through ascending pathways will bring the pain message to the somatosensitive cortex. What was discovered is by stimulating A beta fibers as well, they could activate an inhibitory interneuron or directly synapsing to the projection neuron to cause then a reduction or mitigation or even sometimes a complete suppression of the firing that was happening through the C fibers. This was very interesting. It was quite immediately exploited by Wall, who went to partner with another chap who was called Sweet, and they started to stimulate large diameter afferents through some peripheral nervous system, systems that were exploiting peripheral nerves. But also then at some point there was the creation of the first spinal cord stimulator, which you can tell is quite bulky, and I don't know the details, but I'm scared only at the thought about that being implanted surgically in many of the patients, and I think about the potential drawbacks and side effects. What happens then, at some point in the early 2000s, there was a discovery of minimally invasive neurostimulation and neuromodulation, which then opened a completely new chapter in the subject. The percutaneous leads was discovered they could be potentially sited next to the nerves very precisely by the use of ultrasound, more or less like we do nerve blocks before some type of surgery. The advantage is that they were minimally invasive, less intrusiveness. They could be kept for 60 days as a temporary system in order to be diagnostic for a future implant. And not only they improved the outcomes, but they were reversible, because if a peripheral system is not working, it would be easy to be removed. But how does it work? Well, the physics behind it. Well, there is an electrode, basically, that is located, as we said, very close to the peripheral nerves, which is the target tissue. This electrode will be obviously releasing some energy in the form of electrical energy, the VST, the stimulating energy, and then it would activate the double layer membrane through activation of the ions. A change in the electricity, in the electrical activity of the double layer of a neuron would then start an action potential, and through that, transmission. You see on the upper right figure that I put a little circuit. That circuit is basically showing the first resistor, which is the electrode on the left-hand side. There are two different ways of stimulation or transmission of the electricity, which is the RE and the CE, which we'll speak about in a second. And then once the electricity is generated targeting the peripheral tissue, the electrolyte is basically the interstitium, just for those who are interested to understand what we're talking about in that picture as well. So the two ways of creating energy, one is the Faraday charge transfer, and one is the capacitive charge transfer. They're both employed nowadays, but they've got pros and cons. The Faraday charge is basically a chemical redox reaction transfer of electrons. So there is a newly created type of energy on top of the due dipole that is normally created between charges positive and negative by the redox reaction. So just to give an example about the water, there would be a dissociation of the water in hydroxyl ions and hydrogen ions, which means that you have more positive and negative charges in the milieu. The advantage is that this technique is much more powerful and can deliver a much higher voltage to the peripheral target tissue. But the drawback is that by producing hydrogen ions, for example, you would alter the pH of the environment and possibly create some inflammation. The other thing is that the electrodes in redox reactions tend to oxidize very quickly and become useless. So that doesn't mean that this is not applicable, but it simply means that it has a restricted type of indication. The capacitive charge transfer is when instead the electricity is causing a double layer, an electrical double layer in the electrolyte. So by separating charges negative and positive, causing some energy, that energy will then be deployed close to a peripheral nerve and cause a depolarization, an action potential, which would be much inferior in terms of intensity compared to the Faraday technique, but it would be kind of safer. Of course, we speak about the potential problems that we could have with capacitive charge transfer, which are normally much mitigated compared to the other technique anyway. Here you see a little equation. This equation is showing V, which is the electricity applied to the peripheral tissue, which depends proportionally to the electricity of the electrode, which is the BSTI, the stimulating electricity, and which is obviously inversely proportional to a few of the variables that you see there. Sigma is the tissue conductivity, R is the distance from the electrode. Z is the electrode interface impedance. It is often applied to the Faraday charge. The RAC is representing the internal contact resistance of a specific interfacial component. Basically, in a nutshell, what that equation is telling you is that the closer the electrode is to the target tissue, the more effective it's going to be. The richer in electrolyte is the environment, the more dispersion you have of the electricity. So, when this has implications, of course, in positioning the electrodes, and we can talk about this in a minute. The other thing is the mechanical mismatch that is very important in the physics of the peripheral nerve stimulation. So the modulus is basically a measure of the elasticity of a given material. And the modulus between a metal and the tissue is unfortunately very, very different. And that causes a mechanical mismatch that would translate into increased stimulating distance when the electrode remains rigid against a surface like the body surface that is in constant movement. The non-contact area will create a third layer between the stimulator, the target tissue, and whatever asperity that is formed with fluid filling. And the movement itself of the electrodes can cause inflammation, creating yet again another layer. So we need to be aware of all these things that are part of the physics. Normally, when we talk about physics, we think about the physics of the material. We don't think about the physics of the body. We need to be very much aware that there is a physics that is related to the target tissue. For example, the nerves can be completely different. We have unmyelinated and myelinated fibers. The non-myelinated fibers are small axons of the size of more or less between 0.1 to 1.5 micrometers. They're not covered by Schwann cells. They only lie into grooves. And they have a very high excitation threshold. So, to stimulate them, you need a lot of electricity. And for a prolonged period of time, they have a slow velocity of conduction, which is between 0.5 and 2 meters per second. So they're very slow. You can think about having an impulse, noxious to the finger, and that is transmitted to the spinal cord within a second or even if more. And then they characterize if there is pulse bursts. They don't tend to increase their conductivity, they tend to reduce it. On the other side, we have these other fibers, which are the myelinated. They've got the Schwann cell. They are larger axons between 1 to 20 micrometers, which is a huge type of fibers compared to the previous one. They need short pulses and low threshold for activation, and they have a very fast velocity that goes between 5 to 120 meters per second. There's a completely different business here. In this picture, I'm showing you how in the given time, for example, 10 milliseconds, how the impulse in the myelinated fibers can reach the end of the nerve, and in unmyelinated is still by the beginning of it, which has in the stimulation world huge consequences. There is a table here that I'm not delving too much into. It's talking about the various characteristics of the peripheral nerve. But what we are interested in, very much so, is when a neuron is depolarized on some end of it, that depolarization will travel across the axon, producing nerve transmission. That depolarization is followed by a wave of repolarization when the neuron tends to become refractory to further stimulation. Until then, it reaches the resting state. This is, I think, a very important figure. The depolarization happens if it's intense enough and is prolonged enough, it will stimulate the fibers. That's what happens normally in the A beta fibers. Myelinated, they exploit the gate theory of pain. At the same time, same energy and for same time of application may not stimulate the C fibers, and that's normally what is used to our advantage. The waves, the bursts, or if you prefer, the pulse applied, would be characterized by a few, it can be divided according to shape. The charge amount that is applied, this is basically the charge amount applied, the time of interaction, and the duration. And then, of course, the phase, because, they can be monophasic going one side and biphasic. The reason why it's so important to differentiate between monophasic and biphasic is because on monophasic, there is one type of current, as the positive or negative applied by the electrode, but that would create a dual layer of electricity that remains constantly in the same setting. So if positive charges are on, say, close to the nerve, they would remain close, and they can cause pH lowering and inflammation. So that's why commonly we use a biphasic balance type of charge, because that would reduce the type, the potential drawbacks and the complications caused by even the best possible wires. But at the expense of less stimulation. The point with the peripheral nerve stimulation is that even if we have less ability to stimulate the nerves, the end result would not change just because of the distance. It would be so much reduced to the nerve. Here I'm showing the burst patterns. This is most commonly used because it tends to selectively stimulate the myelinated fibers as opposed to the amyelinated fibers, and would well exploit the gate theory of pain. Mechanism of action, not less important than the physics. The peripheral nerve stimulation is multimodal. It's not just about gate theory of pain. There are peripheral mechanisms which are implicated in the peripheral nerve and when they are stimulated, spinal level mechanism, which is more segmentary inside the spinal cord, and supraspinal mechanism, believe it or not. You stimulate a nerve, it reaches different parts of the somatosensory system, and it would treat pain and even sometimes work on the matrix. The main mechanism, the quintessential mechanism, is the number one, the gate control theory. Basically, PNS delivers pulses that preferentially activate the fast A beta fibers, the ones with a lot of myelin, that are fast and easy to activate, thereby inhibiting the A delta and C nociceptive input at the level of the dorsal horn. That reduces the dorsal horn excitability and diminishes the ascending pain signals, but without changing the nociceptive transduction. This is very important because at once we tend to reduce the pain perception by the brain and the spinal cord, but at the same time, if we were only reliant on this type of mechanism, we would still have the problem of central sensitization and wind-up phenomenon, which I'm going to show you at some point that even this one can be mitigated by peripheral nerve stimulation. So the mechanism two is the peripheral modulation. We're talking about the effect, the action on the peripheral nerves in a nutshell. Is stimulating a nerve either positively or negative. In this case, you see a wave of depolarization with the opening of the ion channels, which is what happens basically to the A beta fibers. But there are times when the electricity can be fine-tuned and regulated in order to create overshooting into the C fibers and completely inhibit the transmission of the pain impulse to the dorsal horn, which is a very interesting way of modulating the neurotransmission. There is, believe it or not, again, a modulation of the inflammatory milieu. So here we see the TRPV1 and TRPA1 receptors, transit receptor potential ion channels, which open and close to allow calcium to go inside when they're stimulated. So if there is pain, there is something happening in the milieu, like, for example, some inflammation or some even a change in the pH would activate these receptors, and there would be a neurotransmission to the spinal cord. But when that happens, even a sensory neuron would intervene, would do something, which is like producing substance P, calcium gene-related protein, which are all interacting with the immune system, causing degranulation of the mast cells, activating plasma cells from the T cells. And that bidirectional interaction between the nervous system and the immune system would self-perpetuate the pain and the inflammation, which can be stopped if we stop these receptors from including calcium, which is what happens when the peripheral nerve stimulation takes over. In this slide, instead, we see what happens centrally. The same mechanism that I described a second ago would inform the spinal cord, which would relay then to the somatosensory cortex, which through a few pathways would go to the hypothalamus, pituitary gland, and the adrenal gland, activating the stress response. That one can also be modulated by the peripheral neuromodulation. We will see that in a minute why. So here I'm saying because there is an advantage in having the wires positioned next to the nerve, because we can be very selective in the area that we're treating. At central level, this slide is showing you basically what this picture is talking about. we have two types of very important second neurons. One is the nociceptive specific, and the other one is the wide dynamic range. The nociceptive specific is very difficult to stimulate, has a higher threshold, and it normally tends to remain stimulated for a short period of time. Instead, the wide dynamic range, they tend to be stimulated very easily, and they can remain stimulated for a longer time, explaining why there might be central sensitization. They normally tend to activate microglia and astroglia, and these neuroimmune cells would then sustain inflammation inside the spinal cord and produce central sensitization, which is what, by altering the neurotransmission in the first place to the wide range neurons, we can reduce the central sensitization and mitigate chronic pain. This is showing the selectivity and specificity of the peripheral nerve stimulation. In this case, in the A, we have spinal cord stimulation. In B, we have dorsal root ganglion neuron stimulation. This is the root stimulation, and this is the nerve stimulation in the periphery, which you can tell, if the red zone is the one in pain, is the most effective, tends to be the peripheral nerve stimulation. Through that stimulation, we can reach, as I explained earlier on, central centers where the matrix for pain is located, and working on the periaqueductal gray, working on the ventral medial cortex, we can then obtain a superior center down descending pathway, which is normally regulating the pain by reducing it. Here I'm explaining how different nerves, noradrenergic, acetylcholinergic, can be regulated. Noradrenergic tend to increase inflammation and pain. Acetylcholinergic tend to reduce it. So, for example, if you stimulate the vagus, you may obtain an anti-inflammatory effect. And now the inflammation tends to bidirectionally interact with the neurons. Here is the norepinephrine that can be stopped. This is a vesicle of norepinephrine that fuses with the membrane and relax noradrenaline and cause more pain and stress, which is normally regulated when an excess of noradrenaline happens in the synaptic cleft. There is an alpha-2 receptor that is less sensitive but tends to be stimulated until the ion channels are then opened and calcium enters. But that's something that we can do straight away with the peripheral nerve stimulation and obtain the same effect by reducing the obnoxious, I would say, type of neurotransmission and reduction of pain. The evidence, and we're going to the end of this presentation, there is plenty of evidence. This is a systematic review that is showing, as you see in this graph, by averaging many papers and 9,000 plus patients, that the neurostimulation is promising because it tends to reduce pain and improve physical activities. What we know is that with 9,270 patients, the pain intensity is reduced at primary endpoints of the study at 6 months and goes up to 24 months. That means if you want to use peripheral nerve stimulation, don't worry, just go ahead. You're supported by evidence. The indication mainly is for focal neuropathic pain, but I could explain to you, probably we don't have enough time, that there are a lot of other indications, like, for example, post-surgical pain, or even, something that is more related to inflammation as opposed to pure neuropathic pain. The difference between the peripheral nerve stimulation and the spinal cord stimulation, we already mentioned it. The peripheral nerve stimulation is focused and it tends to be very close to the nerve. The spinal cord stimulation requires a lot of energy and is not so close. But, the advantage of which is what I said, the advantage is the distance, because with the distance, close distance, you're going to stimulate the nerve without employing too much energy. And these machines can now be fed by a battery that is located outside the body. The advantage is that you can use the ultrasound, the battery is no longer required, and it can be effective for both acute and chronic pain, as we explained, based on the mechanism. The limitation is that it doesn't cover for a wide area, but we never know. For example, in the future, we may have very small devices that can be implanted, say like the size of a nail head, and then can be stimulated from externally, and then you can stimulate more than a nerve. In summary, PNS presents a modern evolution of an ancient therapeutic concept. The mechanism spans from peripheral, spinal, and supraspinal systems, providing robust pain modulation for focal neuropathic condition. The innovations are just to come. I think this kind of technology is in its infancy. And what we're going to see in the next years to come is a big change in the way we treat the pain, minimally invasively from now on. Thank you very much for your attention. I'm pretty sure you will have some questions which I will answer to later on. Now, what I need to do is to disconnect, stop sharing. Thank you very much.
All right, we're going to talk about patient selection, targeting, and some long-term outcomes. I have no disclosures. I want to cover peripheral nerve stimulation of different parts of the body, the trigeminal, sort of the head, neck, occipital, trunk, and extremities. We'll talk about stimulating the motor system. And we'll actually talk about peripheral nerve stimulation for some indications that you may not be familiar with, acute postoperative pain and acute neuralgic pain. So when would one want to consider using a peripheral nerve stimulator? The simplest answer is whenever a patient has pain in a peripheral nerve distribution and you don't really have a better way to treat it. So this patient has ulnar distribution pain. So rather than doing a dorsal column stimulator that may blast the entire arm with stimulation, you can target the stimulation to the nerve and limit the unwanted paresthesias. Now, obviously, with a lot of the paresthesia-free waveforms, this becomes less of an issue. But there are other circumstances where there's body parts that you can't reach with dorsal column stimulation or dorsal root ganglion stimulation, or if you don't have good spinal access due to prior at-level surgery, extensive fusions and whatnot, peripheral nerve stimulation in the extremities or outside the central nervous system becomes much more compelling an option. I like this historical slide, not to go through the history, Mario took care of that, but just to show that peripheral nerve stimulation used to be a surgical therapy. Like, I'm a peripheral nerve surgeon. I used to like doing these procedures, and these procedures are largely obsolete. There can be some small exceptions, but really, you know, in part, people ask, oh, are you sad about that? And the answer is no, because the new technology are so much better for patients. They don't need big open surgery. You don't have extension wires crossing joints and all these complicated systems. Today's technology is so much better, okay? But just even if you use these old systems, just to show you that old legacy technology can still give you pretty good results. And complex regional pain syndrome was one of the first topics really formally studied in a large series. And these patients really got, 50, 60% of them got good pain relief. And this is targeting nerves all over the body. So, and this is CRPS, which has a tendency for the pain to transcend the confines of a nerve distribution. So even for a fairly difficult pain syndrome to treat, even with old technology, you can still get pretty good results. But now, as Mario said, there's percutaneous ultrasound-guided techniques. Here's one of the early ones. We were the first groups back in 2010 to publish this. A couple of people were doing it at the same time. But here's an ultrasound view of a 8-contact electrode next to the radial nerve. Really cool stuff. You can, target these nerves with electrodes, with ultrasound guidance, no incision. And what's really great is that industry started to get interested. And when industry starts working with physicians, then really dramatic advances can happen, because a handful of doctors just working in their labs, it's not as great a way of bringing technology to the world. You really need industry support in a lot of cases to really move these advancements forward. And so we have dedicated electrodes that are designed for the peripheral nervous system to be percutaneously placed. They're stable. They tend not to, fracture, break, or migrate. These external generators, which are small, easy for patients to use, and they're becoming MRI compatible. So it's great. And it avoids a lot of the long wires and implantable pulse generators, which is really where a lot of the complications can happen. Another advancement, which was mentioned before, is we now have 60-day temporary peripheral nerve stimulator electrodes that can be placed. And even though the electrodes are only in for 60 days, there could be durable pain relief once the electrodes are removed. And the majority of patients actually experience durable pain relief. And you may ask yourself, well, why does that happen? There's something about 60 days of pain relief that allows the brain to kind of reorganize, and it kind of tricks the brain into forgetting about that pain syndrome, which is very cool. But that's probably how it works. Then, of course, I'm simplifying it, but that's okay. Now, some of these new techniques, or new technologies rather, still don't give you access to some of these more advanced waveforms that we have with dorsal column stimulation. But some of the newer peripheral nerve stimulator systems are starting to explore some of these waveforms. And so, again, there's always new stuff coming online, and be mindful of that. But there still is a role for using some of these legacy systems. These are not old, but they're percutaneous spinal cord stimulator electrodes that are connected to spinal cord stimulator batteries. But instead of placing electrodes in the spine, we place them along the peripheral nervous system. And again, you may ask, well, why do you do that? It's because some of these legacy systems allow us to utilize these advanced waveforms that you just don't get in the new peripheral nerve stimulator systems. So obviously, all these systems use tonic or low frequency stimulation, but high frequency stimulation, right? The 10 kilohertz can be great in the peripheral nervous system. Burst stimulation, which doesn't really stimulate in the same way that tonic stimulation does. It uses bursts of stimulation to communicate with different neural pathways. It's very cool. And again, you can find success with these types of waveforms in the peripheral nervous system. And some of the best ways to do that are using some of these old legacy systems. And you'll find that the majority of, at least neurosurgeons that do this, use these legacy systems for craniofacial pain, the facial pain, and for occipital distribution pain. Now, it's off-label for anything above the neck, so you got to be a little careful with that. They're not MRI compatible. I mean, the devices are, but they're not approved for MRI compatibility in the craniofacial space, right? So if a patient gets an MRI emergently, it's not going to hurt them, but they won't be allowed to get one electively. So it can be a problem, but still, there's a lot of patients out there that need these devices, and so there is a role for these. And a lot of us in neurosurgery continue to place these. Trigeminal pain, so pain in the face, trigeminal distribution, obviously not typically classical trigeminal neuralgia, but the more constant trigeminal facial pains, trigeminal neuropathic pain, right, from nerve injuries, trigeminal deafferentation pain, post-herpetic neuralgia, great indications for trigeminal peripheral nerve stimulation. And the process is similar to any other form of neuromodulation. They typically have failed non-invasive pain management strategies, drugs, injections, things like that. They've done psychological screenings, they've medically cleared, off anticoagulation. Again, all just routine stuff for neuromodulation. Typically, we utilize a 1 week percutaneous trial. We have these needles that we custom curve to fit the curvature of the patient's face. We put them in under local anesthetic. The trial electrode stays in for a week, and then it comes out. The patient's got a good result. We then put permanent electrodes in. I usually do this under general anesthesia. Again, put the electrodes in, tunnel them to a little incision behind the ear, and then tunnel under the skin down to a battery just under the clavicle. It's very similar to a deep brain stimulator, but the electrodes go along the nerves under the skin. Again, this is not ultrasound guided. This is just using fluoroscopic landmarks. Super straightforward, very low risk. Again, our group and others have shown that roughly 50% of the patients have good long-term pain relief. The big bugaboo with all these devices, though, high rate of complications. These electrodes can migrate, they can break, they can poke through the skin, they can hurt, right? These hardware pain syndromes, which is similar for any other form of neuromodulation. So there's nothing magical here. Other groups have shown similar results, long-term 50% pain relief. Again, lots of complications. So, and you'll see that over and over again in a lot of these studies. Moving on to the occipital distribution pain syndromes. These can include occipital neuralgia, which is a formal sort of pain syndrome within the confines of the occipital nerve, but also cervicogenic headaches, migraine headaches, cluster headaches, hemicrania continua. A lot of different types of headache disorders can respond to occipital nerve stimulation. Depending on the exact nature of the pain, it may be unilateral, it may be bilateral. There's lots of evidence, including some neurosurgical guidelines we did some time ago. There are other studies looking at some of the headache disorders, some high quality research actually in some high impact journals here. Again, good evidence base for the use of these in headache disorders. Again, typically same kind of thing with the patients. They failed less invasive strategies. You do usually a 1 week trial, either unilateral or bilateral, depending on what you're trying to accomplish, what kind of coverage you're getting at. Along the back of the head. I usually put these electrodes in starting in midline and going laterally and superiorly. Again, there are others that start laterally and go medially. It doesn't really matter. The goal is to get the electrodes over the occipital nerves. How you do it almost makes no difference. Again, here's a lateral view. Again, this is just how I do it. There's lots of different variants, and the details are not that important. When you bring the patient back for the permanent one, again, I do the electrodes same way, coil the electrodes under the skin, and then send the electrodes down subcutaneously down to a battery, which I usually bury below the rib cage somewhere. Again, there's lots of different ways to do this. The details don't really matter. It's really dealer's choice. There's lots of literature looking at outcomes. And again, the common theme here with all these is you're roughly looking at a 50% response rate in patients. And we have level 3 guideline evidence supporting its use. There's additional studies looking at, again, different types of patients, headache disorders, non-occipital neuralgia. Again, a little over half of patients doing well, almost 2/3 are doing well. Again, it's pretty short follow-up, right? Not multi-year follow-up, or not like 5-10 year follow-up. But again, you're seeing a really good response rate. And again, look at this, 70% adverse event rate. Again, that's the theme with peripheral nerve stimulation. Hopefully one day technology will advance to get us past these complications, but for now, it's just part of the deal with these devices. Trunk and extremities. This is a type of thing which is not really surgical anymore. In fact, I don't even do these as a neurosurgeon. Our pain colleagues who are not surgeons do this, and they've been having great success. It's percutaneous, ultrasound guided. There's no surgical implant of a implantable pulse generator. It's all done percutaneously, and it's really a wonderful technique. Whether it's the permanent ones or the temporary ones, you can target nerves all over the body, but the ones you'll see over and over again are things like intercostal neuralgia, inguinal neuralgia, knee pain after knee surgery, complex regional pain syndromes. These are the sort of the most common indications you'll see. Again, same thing with the screening of the patients, the pain management first, get off the anticoagulation. And then what's nice about these percutaneous techniques is there's really no trial. You put the electrode in, and if it's a permanent one, you just dunk it under the skin and put on the external battery. And then there's no second procedure. There's no waiting for the patient to respond, then taking the electrodes out, and then having to bring them back to the operating room to do it again. It's a one and done, which is wonderful. And if it's a temporary one, you put it in, it's in for 60 days, and then it comes out. But there's really no trial. You just do it. And it saves money, it saves patients time and cost, and it's great. And there's all sorts of literature to support this. Again, you're looking at older studies show about a 30 to 40% response rate, but that's in the pre-ultrasound era with older technology. The current technology, it's closer to 50, 60% response rates. The temporary peripheral nerve stimulation is great, and there's, again, literature supporting that. You're looking at, again, short follow-up. This is a year follow-up, getting 70%, 75% of patients getting relief. So obviously, you're going to see a drop-off. And again, the long term is probably going to hover around 50 or 60%. But the bottom line is you have an ability to provide long-term pain relief for patients with pain and a peripheral nerve disorder using a device that's not even permanently implanted, requires no surgery, no permanent implant. That is very cool. That's incredibly compelling. And that's why I would really recommend that the audience consider using some of these techniques to help these patients rather than doing more extensive nerve surgery and permanent implants and all the rest. I want to move on briefly. One of the concepts that's become apparent in the past 10 years in the neuromodulation community is that the motor system has relevance when treating pain. It's not just about the sensory pathways. If you can harness the motor system, you can actually make progress treating pain. And this was really first seen in the 2000s when patients who had horrible brachial plexus pain syndromes, their pain would get better as their motor recovery occurred after brachial plexus reconstructions. So there's something about the motor system that attenuates pain. And this is now looked at in patients who've had strokes, who have pain from muscle sagging or even neuropathic pain related to strokes. If you can target some of those functioning motor pathways with peripheral nerve stimulators, you can actually get muscle contractions and pain reduction. And this has been looked at for shoulder pain and for other pain syndromes in patients who've had strokes. Again, about 50% of patients are doing well. And what's really great is you see the pain go down in the trial, and then you get this durable pain relief after the stimulators go in. Axial back pain, right? Hard to treat with spinal cord stimulation. It sometimes can be hard to treat with DRG stimulation, but peripheral nerve stimulation targeting the motor, the axial, motor nerve fibers going to the multifidus muscles, right? So these axial core muscles. If you get motor contractions there, and this is, again, been shown with temporary peripheral nerve stimulation as well as permanent, there's a permanent system that exists also. You can actually get pretty durable and pretty effective axial back pain relief. So again, interesting concept, fairly new, and there's literature out there to support that. Even with the temporary peripheral nerve stimulators, you put these things in, they're in for 2 months, and these are pain levels. You take the stimulator out and they get durable pain relief. There's something about how these electrodes cause this reconditioning of the nervous system that enables durable pain relief. Again, to sort of wrap things up, we're looking at peripheral nerve stimulation in sort of new indications. So patients with acute postoperative pain, right? Something you don't really think about using neuromodulation for. You usually think about opioids, nonsteroidals, things like that. Well, patients can actually benefit from having a peripheral nerve stimulator targeting areas that hurt postoperatively. So think about total knee surgeries or elbow surgeries or foot surgeries. Using sciatic, femoral, brachial plexus peripheral nerve stimulators to show reduction in pain levels, reduction in opioid requirements, and ideally, and I'm not sure if this is in the literature, but ideally reduce hospitalizations and increase patient satisfactions. But again, there's a literature to support this. This is not in widespread use, but there is an emerging literature out there suggesting that peripheral nerve stimulation can be useful for something like this. Personally, in my practice, we've also extended this not just really for people having orthopedic surgery, but I use this pretty routinely in patients who have an amplified pain response after just a routine nerve surgery. So here's a picture of a patient who had a median nerve tumor or something, and then we took out the tumor. And, that beats up the nerve a little bit. The nerve is still anatomically and functionally intact, but it's a little beat up. Some of those patients have a lot of pain. So rather than having those patients try a bazillion different medications and dragging out their postoperative care for weeks or months, I'll refer them to my pain management colleague down the hall for a temporary percutaneous ultrasound-guided peripheral nerve stimulator just above where we operate on that nerve to block the nerve pain for a couple of weeks, as they're recovering. And it can be a really, really great way to get patients pain relief post-operatively without committing them to either long-term opioids or anticonvulsant or antidepressant medication or even a permanent implant. It's a really nice technique. And again, this is, something we're doing just based on anecdotal experience, but patients need to be pretty happy with it. So it's an exciting field. There's room for advancement, lots of room for getting these systems better. The through line here has been that all these systems have high complication rates. And although the complications aren't severe, patients aren't really dying or getting disabled, which happens a lot in neurosurgery. It's more just like electrodes can break and migrate, and it's sort of more an annoyance. But, as technology gets better and these systems get smaller and stronger, I imagine a lot of these complications will fade away. That'll get done with abundant physician industry, innovation, relationships. I personally don't have any relationships with industry, but I think it's great that people do, and they've really pushed the field forward. There's been pretty rapid advancements. Peripheral nerve stimulation was a pretty dead field 15 years ago, and just past decade and a half, it's just blown up, and it's amazing. Craniofacial pain, headache disorders. There's a whole field of peripheral nerve stimulation looking at cognitive, mood disorders, thought disorders. We haven't even touched on that with this talk. It's a whole nother, forget webinar, it's a whole nother years and years worth, a lifetime of studies, careers can be made about, with this. So think about that if you want to put it incorporate as part of your practice. Chronic pain, acute pain, these are minimally invasive, safe and effective techniques. They're evidence-based. And I think if anybody has an interest in this, you should pursue it because these procedures are a lot of fun and patients can be very happy and it's quite rewarding. So thanks everybody for their attention and I wish everyone luck.
Phenomenal talks. Phenomenal talks. Thank you to both of you for a really comprehensive run through. I can well envisage this becoming almost an online Bible for us on peripheral nerve stimulation and neuromodulation. So there's been a handful of questions that have come through here that I'll just read out, and please keep them coming if you have any more. One question to start with is a question about using chronic or using long-term peripheral nerve stimulation for pain relief, so for chronic pain relief. Has anyone ever noticed any local muscle hypertrophy with that? I presume because of the ongoing stimulation that has been received in the area from the nerves is what he's getting at.
I have not. Now, I think the best place to look for that, though, is probably some of the multifidus stimulators that people are using. There may be some work looking at cross-sectional muscle, mass. I'm not that familiar with it. I don't do the procedure myself, but to answer that question, you may want to look at some of that literature. There may be some out there that shows that the axial muscles may bulk up, but I don't know that for sure. You'd have to you'd have to
I
look at.
think Chris has taken the right example, is the reactivate system. Sorry, I'm talking about, it's slipped out of my mouth, but is basically the system that is applied to the medial branch. That is the nerve that is innervating the facet joints where the vertebrae are joining to one another. That is normally burned by the pain physician to reduce the afferent, the pain afferent that comes from the joint that is now, say, arthropathic and destroyed. However, is the same nerve that innervates the multifidus muscle, which is one of the nerves that is in charge of maintaining the spine and its stability. And now there is an increased questioning of burning the nerves. That is come at the same time. Now there is a study that is multi-centered here in the UK that's been run just to ascertain the effectiveness. I personally believe more in conservative management, and while that does not demonstrate hypertrophy of the muscle, when one looks at the multifidus muscles, they tend to be, in people who suffer from spine pain, they tend to be infiltrated with fat and with fibrotic tissue. That is not completely reversible. If the muscle is stimulated, or even better, if it is used as in exercise and with physiotherapy, that degree of fat infiltration tends to be reduced and the functionality of the muscle recovered. And according to the evidence, the pain gets better.
Thank you for that. Another question here. In fact, perhaps I'll tie two of these together. So, Professor Winfree, for yourself there, and both of you, in fact, you're advocating the use of peripheral nerve stimulation post-op instead of indwelling nerve blocks and indwelling nerve catheters. So perhaps are you advocating that that's the future? And someone else is asking particularly for gynecology procedures as well. So could PNS be used to work post-gynecology procedures? And also another one here, could it be used for dysmenorrhea? So
well, I would say for pelvic pain, I have tried peripheral nerve stimulation for pelvic pain and have not had a lot of success with that. I think a better neuromodulation technique for chronic pelvic pain is probably the bilateral L1 and S2 DRG stimulation that Corey Hunter developed some years ago here in New York City. I think that's become kind of the standard neuromodulation technique for pelvic pain. Probably not peripheral nerve stimulation, quite frankly. Now, that doesn't mean this is the final answer, but my understanding of what tends to work for patients and what I've tried to do in the past and haven't not worked, I would, if I were the patient, that's what I would choose as a therapy if I had chronic pelvic pain.
Okay.
So I'm using a different computer. Otherwise, I will show you a video clip on how sometimes the wires can be positioned next to the sternum for treating chronic sternal pain. I've positioned catheters, but not specifically peripheral nerve catheters for the treatment of that post-surgical pain. But I know a colleague of mine in London has a little database where he's got a small number of patients for whom he's been stimulating the anterior cutaneous branch of the intercostal nerves through peripheral nerve stimulation. He's not published, but he says that he works. So that's all I can tell you.
Well, historically, back in the 2000s, in early 2000 teens, we were using peripheral nerve field stimulation to treat just about any kind of pain you can imagine. Those were basically converted to what are called T codes, which are temporary codes, which eliminated all reimbursement for them in the United States in 2012 with a coding update. And so that procedure was used for a lot of different chronic localized neuropathic pain syndromes, and it basically died in 2012 because nobody can get reimbursed for it. So if you can target a specific nerve and show that on an ultrasound, you may be able to get a peripheral nerve reimbursement code for it. But if you're doing field stimulation, it's probably not going to happen in the US.
So on that note of targeting a specific nerve, there's a couple of questions coming in here for specific diagnoses, such as chronic pancreatitis or trigeminal neuralgia. Do we advocate that peripheral nerve stimulation, neuromodulation could be used to target these particular diagnoses people are mentioning?
I mean, I have an opinion. Mario, you want to?
So it is theoretically possible because, in pain, we tend to stimulate the sympathetic chain alongside the lumbar and thoracic part. Well, we tend to do PRF, peripheral stimulation, or we tend to inject phenol so that we stop those from working. So I personally have never heard of that usage, and I've never used it in myself. But in theory, it's very, very possible because all you have to do with the ultrasound is to put a curvilinear probe by the flank of the patient. You visualize L1 and you can advance a needle next to the anteriorly to the body of the vertebra. You would have the aorta, so you have to be very careful. But you would, with the ultrasound, you would visualize it. So in theory, with the ultrasound, and if you like, in addition, you could use the fluoroscopy and get there. And the point is, as you know, Chris, one of the limitations of the peripheral nerve stimulation is to leave the catheters without migration, which in that area where you have diaphragm that is going up and down, I don't know if we probably need to develop a system that remains more firmly anchored to the place where we're going to leave them. But otherwise, it's a very theoretical, plausible application.
I think if I were a patient with pancreatitis type pain, so upper abdominal pain, I would probably rather trial a T5 to T7 spinal cord stimulator, actually, to target upper abdominal pain. You go above where you would normally do it for back pain, like the 5, 6, 7 area or 5, 6 area, either with or without nerve root stimulation.
Absolutely. I mean,
I would do that before.
If, of course, we're thinking about closing our view on only peripheral nerve stimulation, the answer is that it is possible, but it goes with it. And then if you put some wires up to T7, you can actually, that there are different waveforms that you can utilize, and it would be very effective.
Yep. Somebody mentioned that Curonics has a full FDA, full body MRI. That's kind of cool. I don't know that if I knew that. I thought all the craniofacial stuff was not FDA approved for MRI, but that's good to know.
Yeah,
there's some questions in here on. There's some questions in here on funding as well, in terms of funding of stimulation in both the NHS and also in the USA. So for models for reimbursement, I certainly know that in the UK for the NHS, that actually the NHS structure itself will reimburse commissioned centres. So in essence, it's fully funded if only you can set up a centre to do that. And there's about a dozen centres in the NHS at the moment. With more potentially coming up. But it's also about funding the training and the experience and decision making, so the team behind it, for implementing it in the longer term follow-on. What's the funding situation in the USA? Can you shed some light on that, Chris?
Oh, it's a total disaster. I mean, remember when I was quoting a lot of the patient outcomes, 50%, right? Like pretty much every answer I gave, 50%. Well, I'll tell you right now that about 50% of our peripheral nerve stimulators get denied eventually. Half the patients can get their device, which is really terrible if you're a patient, because you get this chronic pain that nobody else has been treating. You finally find a doctor. He's like, yeah, I can help this potentially. Got this device. You got a coin flip shot at it helping you. Let's do this. And the patient's like, wow, that's pretty compelling. And then boom, grinds to a screeching halt because their insurance company says, nope, it's experimental. Even though there's guidelines, there's randomized prospective, this and that. Nope, experimental. And then they say no. And since they're the ones paying for it, the patients are kind of stuck, right? And they've got these silly insurance documents that say, well, it's experimental. They're just making it up or just saying that, but that's what their document says. And so appealing is hopeless. So your office spends hours trying to get these things appealed. It never works. Not never, but it very rarely works. And so you got all these patients out there that can benefit from this procedure, and their insurance companies are just telling them no. And it's brutal, but that's just the nature of the system. And so,
and even though the business plan could actually say you could take them off their pain medications longer term, with this as an alternative solution, I mean, is there a business case to say it's cost neutral?
Well, but you understand the business model of U.S. insurance companies. The probability that one of your patients, if you're an insurance company, is going to be off of your plan and on a new plan next year is very high probability. So if you can delay that patient's care to next year, there's a high probability you won't have to cover that care. So they don't care about that because that's not part of their business model. Their business model is what's less expensive this year, okay, and what's what's next somebody else's problem next year. Okay, this is why patients get denied surgery in December, because it'll get approved. It'll get approved in January when that surgery's some other insurance company's problem. It's a big problem in the US, right? So don't come to the US for healthcare, right? At least if you're going to use insurance. Paying cash, it's a whole different matter.
Funding is always challenging. There was an earlier slide on outcomes after 2 years. You mentioned. So in fact, Professor Cibelli, that was with yourself. You mentioned studies up to 24 months. Do we know of longer term? So a question here: Do we know of any longer term outcome studies for 5 or 10 years? I mean, I suppose peripheral nerve stimulators are relatively new in partial answer to that question. So I suppose we're still waiting for our 5 and 10-year outcome studies. Have either of you got any knowledge on these?
Yeah, so basically, there is a study from North Carolina. It's small. Yeah, I can't remember if it was 20 or 30 patients. It's not big, but it's an extremely interesting study. The reason why, as Chris anticipated earlier on, there are sometimes applications of the peripheral stimulation for only a limited time window. And these people, instead of implanting a peripheral nerve stimulator for, say, a couple of years, they did it for 60 days. Now, I can't remember what they were treating, but I can give you the evidence, I mean, if you want. I mean, it'd be available. And they did a 4-year follow-up, and they found out that you stimulate for 60 days, and you have more than 65% of the patients treated for that given pain still having relief after 4.7 years. So this study is amazing in 2 different ways. In one way, because it's telling you it can be durable. In another way, because it's telling you you don't have to stimulate for very long. It's basically based on what pain consultants still do nowadays, i.e. we tend to do PRF, is a pulsed radio frequency treatment of some nerves. And I'm having a patient, for example, that exploded on some mines, because my hospital is a Ministry of Defense center. I'm serious. Who comes for PRF every 6 months and is going home very happy. He's experiencing pain mitigation, according to what he says, at around 50%, and he's quite durable. So that patient, for example, would be a candidate for that kind of treatment for 60 days and see if that can be extended for much longer. The other thing, since we're here, NHS funding, basically it's very simple. NHS England is giving you the money for the device and the equipment. And you as a hospital need to provide the funding for the person who's doing it, from the personnel in theatre, in the operating theatre. That's it. So, it's a part funding, but in my opinion, it's pretty good. And there shouldn't be no excuse for somebody who wants to pursue this kind of treatment in their department to be stopped because of funding reasons.
Thank you for that plug. Professor Winfree, just on the duration, have you got any other knowledge of any other longer term outcomes? I mean, that's always something we're always looking for. Certainly a long time, what Mario said.
I've got an anecdotal story. Like my oldest existing patient I've had her for 20 years, and I put in some combination of occipital and trigeminal branch stimulators. And she comes in every year, gets her battery replaced, and she's still getting pain relief. This is anecdotal, right? Meaningless in terms of actual scientific knowledge and data.
Yeah.
But I'm telling you, you get these long-term patients who come back every time their battery runs out and they want a new battery. And so for that patient in their world, it's made a huge difference, and they've got a good long-term outcome. Now, there's also plenty of other patients who, the pain peters out, or the stimulation, the therapeutic response peters out after a few years, and you end up taking the devices out. I don't want to give the impression that the majority of patients are 20-year responders. The majority are not. The majority, use the device for a few years. It gives them some quality of life, and then they end up getting bored with it, or moving on to the next thing, or the pain goes away, or it stops offering so much usefulness, and then they end up taking it out, or you just turn it off and leave it in. But the way I see that is, if you get the patient 4 or 5 good years, all right, where they're playing with their kids or grandkids, or they're enjoying their retirement, and then 5 years go by, and then they're not happy with the therapy, and they move on to the next thing, I'm going to log that as a win every time, right? Is it ideal? No, but that's still 5 better years than sitting there wanting to kill yourself because you have this agonizing pain syndrome that no one's listening to you, no one's treating, no one's helping you with. So you gotta understand what an actual win here. If you're a patient, put yourself in their shoes. Would you take 5 good years? I probably would.
This tags back. There's still a number of unanswered questions, but I'll maybe just give the last one or two. But to an earlier question asking about potential side effects here, or are there any implications because of? I think this talking for Professor Cibelli actually, Cibelli's when he was talking about segmental stimulation. Does that have any side effects that we know about? I think we're referring to, are there any other implications because this is rerouted through the spinal cord with the sensory signaling?
So when you're talking about, can you hear me? When you talk about segmental stimulation, you're talking about something that is applied to a peripheral nerve that works in the spinal cord at the same segment, i.e. the same dermatome where the input is going. So for example, if you're having heart-related pain, you can treat the nerves that are the thoracic nerves that are going to the chest wall. They have nothing to do with the heart. You apply a stimulator there because they're going into the same segment. That you can fool the brain to think that stimulation is coming from the heart, and you may have heart-related pain treated. There is now anecdotal evidence, but I'm using it because it's a bit harsh to do that. At the moment, I'm using it with the TENS machine, the transcutaneous electrical neurostimulation, which is just applying a few pads by the nerve. So there is evidence, which I didn't want to mention earlier on when Christopher was talking about the pelvic pain, because he's a bit, it's very inconclusive at this stage, but I'm going to mention it now. So basically, if you stimulate the tibial nerve with a peripheral nerve stimulator, you may obtain treatment of pain syndromes that are pertaining the pelvic pain. For example, prostatic pain or femoral pelvic pain in several of the conditions that they normally tend to have. What I'm advising people is to use a TENS machine, but according to a couple of case reports, that is a possibility, and we may well think about it, because citing a peripheral nerve stimulated by the tibial nerve is not complicated. Now, the thing that happens there is that the stimulation that you apply to the periphery that goes into the dorsal horn, as I explained, interacts with wide dynamic range neurons. Those are projecting straight away to the brainstem and then to the limbic system. And they can activate the periaqueductal ray and the rostroventral medulla to then project back and apply an extra layer of the gate theory. However, because they go up to areas such as the amygdala, the hippocampus, etc., still in the limbic system, they can cloud emotions. Most of the times they tend to have a relaxing effect, because at the same time when they're treating pain peripherally, they would affect the matrix. But if I'll give you a simple example, I don't think I would ever apply a peripheral nerve stimulator to somebody who suffers from fibromyalgia, because the dynamics there, the psychological dynamics there are such that they're so complicated that the patient may come back a lot worse off. The same thing applies when you're offering injections. I only injected a patient with fibromyalgia twice, and I regretted it really badly. So I think the same would apply to this, because he would affect emotional stress, and the patient may come back with a completely different result.
Paul, you're muted.
Your microphone.
Thank you all. So challenging scenarios underlying all of our patients. So that's been all really phenomenal. Perhaps just as the final thought or the final question for us both, which is the future, and a question that's asked here. So if money and time weren't a limitation, what study do we feel peripheral nerve stimulators that we could do on peripheral nerve stimulators that would be most significant for its clinical impact?
I would have arranged that it's literally endless. I think this is, I do research myself. I got 2 grants at the moment on chronic pain. And I'm really hoping that I could start with peripheral nerve stimulation. I've got some other ideas on the nerves which are not strictly related to peripheral nerve stimulation. But for example, if you put a guide in a nerve that is damaged and you can pass some current there, and the damage is not, the gap in between the two ends of the nerve that is now damaged is not too extended, you may guide the regrowth of the axons, and you may obtain a nerve that was completely unfunctional to develop some functionality eventually, because we know that they tend to regrow. The trouble is that they tend to regrow in a very untidy way, and so there is no meaningful function as the regrowth happens. As the only thing that is normally left is chronic pain. Because there is neuroma information. That you know that very well, Paul, because I'm sure that you do this surgically as well, and I guess probably Chris as well. The other thing is for muscular spasticity. Christopher so well illustrated, and he showed even a picture of a nerve stimulator that can be applied to muscles. I would do extended research on the muscle recovery in those people who've had a stroke or some kind of problems that are then leaving them with muscle spasticity. I've been treating them in the past from the anesthetic viewpoint when they were coming for surgery. And I know that it's absolutely a horror to see somebody in their teens or in their 20s already so much in trouble because they had a road traffic accident and they left on a wheelchair with the muscles completely left spastic. So if I could, I would do a stimulation of their muscles, because we know that it would relieve their pain to start with. But then if it would help relaxing the muscles and reacquire some functionality by the development of newly acquired pathways for that muscle to be controlled, that'd be amazing. So these are the two ideas, but there will be, I think the sky's the limit.
Can it be a panacea there? Professor Winfree, any burning questions that you feel are about to come out?
Well,
Final words.
And that you mean any pending research that I'm more, no, not really. I think what we need to do is provide ideally clinical trial or prospective data registry studies, data that really hammers home to insurance companies that this therapy is safe, it's effective, provides long-term benefits and long-term cost savings, to basically force them to pay for these therapies when appropriate, right? That's what I would like to see. And obviously, the technology advancements to reduce complications, to expand indications. Like I said, there's this whole field of research looking at thought disorders, mood disorders, psychiatric disorders with peripheral nerve stimulation, vagus nerve stimulation. It's great stuff, and it needs to be pursued. Stimulating peripheral nerves after peripheral nerve repair to help enhance the recovery process, right? Peripheral nerve stimulation to help control muscles in patients with higher, above level spinal cord injuries, right? The possibilities are endless. I don't have any one burning question I would need to do. Phrenic nerve pacing, right? For people with diaphragm disorders. I mean, it's the whole thing that people really aren't talking about. I mean, and that's some of the sort of work me and my collaborators are doing. There's a ton of things that you can look at, but I think right now the take-home message is that for people in this audience, peripheral nerve stimulation is a great technique for you as a provider and for your patients. It's safe, it's effective, it's minimally invasive, and it can really help people deal with chronic pain that really nothing else can help with.
Those are wonderful finishing words for this topic tonight. So on that note, I will thank our certainly both of our presenters here, Professor Cibelli, Professor Winfree. Thank you for attending. Thank you everyone for joining and watching and tuning in. This will be present on YouTube as well, so we'll store that there. And thank you so much to all the GNF and Stephen for organising all of these webinars. Great.
All right, thank you.
Then everybody.